give to our community. So thank you so much for being here. Let's give Dr. Arnold a warm welcome.
Well, thank you. I'm actually sort of semi-retired. So I want to know who's seen this before.
I'm not hungry! You're having one more bite. No, one more bite.
Yeah. This is where we don't want to go. And how many of you have seen this before? And this. And this. So a lot of things aren't necessarily because of an FAOD, but there are some things that do make your life unique and different. But somehow, sometimes this is how parents feel, where, you just don't know what direction to go in because none of them seem right and everything seems like the wrong way. So let's talk about you for a change. Instead of talking about your kids, let's talk about you. So I think probably anybody in this audience could give this talk just as well as me. What does it mean when you have a chronic illness in your family? The stress, the worrying, the waiting for the other shoe to drop, the stress on your relationships, on your other children, effect on your finances, your career, the quality of life for the family, the fear of missing out, the hospitalizations, taking attention away from other siblings, and parents and siblings missing life, and the patient missing life experiences that they don't necessarily want to miss. So I went to the literature and looked to see what was in there, and I did find a couple of studies unique to fatty acid oxidation defects. One was a study from Germany where they looked at 63 patients who had various long-chain FAODs, and they reported on the various stresses that the families reported experiencing. So my main complaint about this particular study was that there was a lot of variability in severity. So 19 of the 68 required a feeding tube after birth, after the first year of life. But the frequency of hospitalizations per year varied from 0 to 40. Well, I just don't know how you can possibly really compare the experiences of somebody with 0 hospital admissions in a year to somebody with 40. But there's some good data here. They did find that about 2/3 of the mothers and a majority of the fathers thought their daytime functioning was impacted by sleep disturbances. Just, having to get up, feed the child, worrying about them at night. And about half of the mothers and fewer of the fathers said the child's disorder caused relationship conflicts. But also a good number thought that it brought them closer together. This is a second study that I found looking at the impact of long-chain FAODs for patients and caregivers. And unfortunately, this study actually focuses almost exclusively on patients. There's not a lot of caregiver information in here. But they thought that 70% of the caregivers reported an effect on their employment, the parents' employment. They changed jobs. They had to stop working. They had to reduce their hours sometimes. They actually had more absenteeism compared to a typical control group. Some of them had to turn down opportunities that might have been better for their career, but not so good for their family. And the most common reason that they gave was because of the child's frequent hospitalizations. So, when you parent a medicalized child, what's normal? Certainly, particularly at the beginning, pretty strong emotions. Anger, disbelief, guilt. Later on, there tends to be sadness, sometimes loss of confidence, sometimes social isolation, which of course is why this group is so good. Guilt and worry. You don't get to pick the genes you give your kids. It might be a little bit scary to live in the world when you can, which probably isn't all that far away. But at the moment you can't. Worry, financial problems, and everything is harder. It's, you don't just call the 16-year-old next door neighbor to babysit so you can have date night with your spouse when your child's got a feeding tube. It just makes everything harder. And sometimes when the child is ill, it just uses up all the air in the room. And there's just not really time to think about what's happening to you and what's happening to the siblings. But it's important when things calm down to try to get back there. So interestingly, the research on medicalized child, which now I'm talking about general, not just FAODs, because there's just not that much out there on FAODs, the lack of control and the uncertainty was a big stress for parents. Many studies suggest the stress becomes a little better as they get older, although I understand in one of the roundtables yesterday, one of the parents strongly disagreed with that. It gets different, at least. I know when I was a resident, one of the attendings was always saying, "You think it'll get better after residency, but it gets worse." And it actually was better, but it's different. The stresses are different. As my sister used to say, small children have smaller problems, big children have bigger problems. But research has found that in particular, it's the mothers who bear a lot of the stress. So one study found that stress and, interestingly, PTSD, post-traumatic stress disorder, you heard a little bit about that earlier today, and the mothers of children with type 1 diabetes, and they said the mother's stress also impacted the child's metabolic health. And that created a second problem, that your mother's stressed and then she's worried about being stressed because her stress might hurt her child, and so she just gets more stressed. But the dads don't get off scot-free. There's not as much work done on dads, but that this study was type 1 diabetes mellitus, and they interviewed 43 fathers. And they also found that paternal stress had important implications for the health and behavioral outcomes in the children. So you're in a cycle. You're stressed. You worry about being stressed. What is your stress doing to your child and your family and yourself? And that just makes you more stressed, right? It's a cycle. It goes around and around. It's enough to make you scream. I love this slide. So, can you break the stress cycle? Well, there are some things you can do. What's a parent to do? Acknowledge that you're stressed. Give yourself grace and permission to be stressed. Acknowledge that it's normal for you to be stressed. Join Mito Action and phone a friend. Get therapy. Accept that you're not a perfect parent and sometimes you're going to screw up. And then learn to let some things go. If you valet parked when you got here and the inside of your car looked like a bomb went off, it's probably okay. The valet parkers, they've seen everything. If your kid goes out and, gets muddy, maybe they won't be able to look perfect 24/7. Whoops. So one of the things that I find people, if you need permission to cry, do it. But when people ask you for help, when they can see that you're stressed, sometimes you're just too stressed to think about it, or you're just too embarrassed that, you have this mountain of laundry, it's so big you don't want anybody to see it, or, you just don't really even have time to think about what they could do for you. So during a time when you're not so stressed, think about that. So when somebody comes in and says, "What can I do to help you?" have an answer. Go attack that mountain of laundry for me. They might not fold it the way you like, but it'll be clean. Walk my dog for me. So what are things? Have an answer now when you're not so stressed and you can think about it a little bit. And then take a break. And most hospitals and places do offer respite care if you can get into their program. So maybe you can take a weekend off and somebody will know how to use your feeding tube and be careful enough to feed your child. So I love this slide too. I made it many years ago, but this is my version of put your own oxygen mask on first. So, Timmy's drowning, Lassie get help, and it turns out that, Lassie goes for swimming lessons. Sometimes you have to help yourself in order to be able to help your family. So it's not only okay to take care of yourself, it's really important. If you're the engine holding your house together, you have to be able to hold your house together. You have to put your oxygen mask on first. Well, what about siblings? I was fortunate enough to be able to sit in on one of the sibling group sessions here, and it was wonderful. It was just wonderful. But in reality, there's not a lot of research. So when I went out looking for research, I found this quote. There it is. Almost nobody studies siblings. And this was from diabetes literature. So sometimes they'll be jealous that their sibling's getting extra treatment. Sometimes they're worried about their sibling. I saw a lot of worry in that teen room. Sometimes they worry they'll get sick too. And in fact, young children do a lot of magical thinking. They think that because they misbehaved, they caused their sibling to be ill, or that they'll make themselves ill. Sometimes they feel guilty because they're not ill, or guilty because they want more attention when they think they shouldn't be asking for it. Resentment is normal, and it can make sibling rivalry worse. And then we're going to talk a little bit more about some of the professional help resources, but a lot of hospitals have sibling groups. Often they're like through the cancer center, because that's the one that has the biggest patient population. But I did find a couple of studies. So one of them looked actually at almost 7,000 children and over 18,000 controls. And they did find that the siblings and the parents had increased rates of healthcare encounters, diagnoses, prescriptions, suggesting that there were increased physical and mental health problems associated with living with someone with a chronic condition. And PTSD, you had to talk earlier today, people tend to think of PTSD, post-traumatic stress disorder, as somebody who loses it when the fireworks go off on the 4th of July because it takes them back to combat. But in fact, it can be a lot more subtle. And it can happen, interestingly, not only to the child, but to the parents as well, and to the siblings as well. And I think you heard about that in a talk earlier today, so I won't spend any more time. But there's good news too. So siblings can experience increased empathy, maturity, understanding, patience, and love. And I have to say, in the teen room that I was in, I saw that. So when I sent Stephanie my slides, she asked me if I knew about SIB shops, and the answer is I did not. SIB shops is a group that was started at the University of Washington for the siblings of people with special needs. There's now more than 550 chapters worldwide. The chapters are sponsored by hospitals or agencies or programs. And if you go on their website, which I have here, they have information on how you can get started in trying to get a local one started. So my question was, why don't I know about this? And so when I went and looked on the Pittsburgh site, there's only one site in Pittsburgh, and it's run by the School for the Blind. So it's not associated at this time with Children's Hospital Pittsburgh, which is why I didn't know about it. But they have chapters everywhere, and they have information on how you can help get a chapter started. And it's not therapy. It's not a group therapy. It's just more opportunities for the kids to get together, to play, to relax, to get to know each other, to share experiences. So it's monitored by professionals, but it's not a professional therapy group. So it brings us back here. Get help. Maybe the help is through SIB shops. So how do you understand your parenting and how it's affecting your child? And you hear all kinds of words thrown around, helicopter parents and, et cetera. I actually live with a helicopter parent, but we won't go there. But there have been basically 4 basic groups described: uninvolved, permissive, authoritative, and authoritarian. So I guarantee nobody in this room is in the uninvolved. You would not pick up and come to Detroit if you were not. But these literally are parents who are really quite neglectful of their children in every way. Permissive, well, whatever you want. So think you've been cooped up in the car driving to Detroit, and you get to a restaurant for dinner, and the kids are running all over the restaurant and creating chaos. And the parents are like, well, they've been cooped up in the car for 8 hours, of course. And, and as long as nobody complains, it's okay. So they're more lenient. But they generally do have rules. The rules are just more lenient than other parents might be. Authoritative, let's discuss this. These tend to be more parents who are democratic about it. They're willing to understand where their kids are coming from, but and they have some flexibility, but, are not, they're gonna take the kids outside to play for 15 minutes and then bring them in the restaurant and say, you'll sit still. And then the demanding parents who are, instead of being authoritative, they're authoritarian. And they're the ones who are gonna say, yeah, you've been in a car 8 hours, I don't care, you're gonna sit there, sit down and shut up. You're gonna do it because I said so. So, because I said so, let's discuss it, kind of whatever you want. So, on the extremes, people who are overly permissive and overly authoritarian, it does cause problems for the kids in the outcome. But people who are just kind of lean a little more permissive, they've got wider limits, wider leeway of what they'll accept from their kids, but there are limits and they enforce them. Or people who are stricter, but are still fair and they still have justice in their discipline. With all of that, generally the kids are okay. What really causes problems is when you've got one parent who's up here and one parent who's down there. And that can actually cause more problems. So parents really need to provide a united front. And when you've got parents who are sort of at different ends of the spectrum, one of the things you have to ask yourself, how different are our parenting styles? And how were you raised? What kind of house were you raised in? Were you raised in a more relaxing, the traditional sort of American upbringing as we were more permissive with our toddlers, and then we wanted to be stricter with our teenagers, which kind of doesn't really work. And the sort of a more traditional model was like the Europeans, where they were stricter with their toddlers and more relaxed with their teenagers. So one of the most interesting things I learned was describing whether a home is a beehive or a cocoon. A beehive where you run around getting stung all the time, or a cocoon where you're sort of wrapped in love and niceness. And of course, you don't want the extremes either, because if a house is too much of a cocoon, no one will ever leave it. So again, moderation in all things. But what kind of house do you live in? And do you want to change that? I grew up in a beehive, and I was determined that I would not. I would not convey that down to the next generation. So after I was putting this together and writing all this about parenting, I came across this article in the Washington Post, affectionately known as WAPO, basically saying, are we giving people too much parenting advice? Is it getting in their way of being good parents? And I think to some extent that can be true. If you're, the idea that you should be, centering the child, but parents have a lot going on in their lives. So, I would say do your best. Do your best, but don't believe everything you read or everything you hear. But don't I have to be authoritarian about food and medicine? Yeah, you're going to take that medicine because I said so. You're not going to eat that because I said so. That's a tough one. The best advice I can give you is to establish what's negotiable and what's not negotiable early when the kids are young. Nobody has any trouble with not sticking your finger in light sockets being non-negotiable behavior. But they have a lot more trouble with other things. So if you think about what does a child want to wear, they want to wear shorts to school when it's snowing. A more permissive parent might say, well, I'm going to throw a sweater and slacks in their backpack on the sly, so when they get to school and learn from this mistake, they'll know. The authoritative might sit down and say, we're going to look at the thermometer, and if it's, if it's under 65 degrees, no, you can't wear shorts. And the authoritarian parent says, you're going to wear that because I laid it out. Kind of figure out early what's negotiable and not negotiable, and hopefully eating will be something that becomes non-negotiable. Don't try to reason with a toddler. I'm sure you've all tried that. Try to be consistent and try not to reward entitlement. It's hard, especially when kids are in the hospital and they're cranky and they're sick. And sometimes you have to be a little more flexible about that, but try not to reward rudeness. So this was a long summary to read, but I copied it directly from an article on family stress. Again, it was from the diabetes literature. So it's likely to increase conflict, particularly in adolescence. Nowadays we're learning that we need to have more attention to the role of fathers, more attention to the stress that's on the parents, and we need to do more studies. So parents may need support in managing their own stress. And that takes us back here. Put your oxygen mask on first. And sometimes you learn to save Timmy by going for swimming lessons with a therapist or a friend or somebody from FAOD group or something. So
I'm not hungry! You're having one more bite. No, one more bite!
let's go back to food now. When Stephanie asked me to do this, I really thought it would be so interesting to give a talk on what happens to the relationships with food in a family where a child's on a restrictive diet. This has kind of long been of interest of mine, but it's not one that's easy to get funded to actually do the work. So how does FAOD affect eating? Well, with MCAD, we emphasize a heart-healthy diet. We really don't emphasize fat restriction in MCAD, but we'll get to that. I had one patient once who had the worst MCAD I have ever seen, and acted, in fact, like a long-chain fat problem with feeding, but it turned out when we got able to do deletion duplication DNA studies, she had no gene. Her MCAD gene, it's not that it made a protein that didn't work very well, it wasn't there. But pretty much for 99% of people with MCAD, it's a heart-healthy diet. Avoiding prolonged fasting and the problems when the patient's ill. So 99% of kids with MCAD, if their appetite's intact, they're going to be fine. I mean, if you think about the way young children eat, they usually eat a good breakfast, a moderate lunch, dinner, not so much, And as long as their appetite's intact, that's usually okay. For the long chain, your diet's going to have to be what your clinic prescribes because there's so much variability in severity, diagnosis, age of onset. Some people can follow a heart-healthy diet, some fat-restricted. But I have found that the sickest patients often have some anorexia. They don't actually have a really good appetite. So there's actually very little information about how restricted diets affect the rest of the family. So what affects how children eat? Appetite, are they hungry or not? Habit, what do they usually eat? Social cues, temperament of the child, availability, what the family's eating, family meals. So looking at the first three, appetite, habit, and social cues, and particularly in the kids with the long-chain fat disorders, but also some with the medium, we feed them when they're not hungry. We feed them because it's time to eat. The clock said it's time to eat now. And they then often just don't learn normal hunger and feeding cues. And to some extent, we can't really change that, but it's just something to keep in the back of your mind. If you're chasing your child around with food, one more bite, you're gonna get into trouble. Some of it's innate to the disease, and some of it's basically caused by us. Some of the kids will get food preferences and aversions. In my experience, a lot of the kids with the more severe long-chain fat defects like carbs. They like bagels. They like pizza with fat-free cheese on it. And then you can set up anxiety and behavioral patterns about eating. And when you're chasing your kid around the house with food, saying one more bite, there's nothing they'd like better than to tick off Mom by not taking that bite. So if you can avoid that, try. So try to normalize your relationship with food as much as possible. Try not to make food an issue. But if you have a child who has really significant appetite and eating problems, I've been a doctor for 38 years now, and I have never met a family that was sorry they put in a feeding tube. And the most common reaction is, why didn't I do this sooner? So instead of sitting at home fighting about food, you can let them eat till they're happy, put the rest of the meal in the tube, and then go to the park instead of chasing them around the house with one more bite. Also, sometimes you can avoid hospital admissions because if they're not eating and you're afraid they're going to throw up, or maybe they threw up once, sometimes you can drip something in slowly with a feeding tube, enough to keep them from vomiting, but to get something in and avoid a trip to the hospital. So I personally am a big advocate of feeding tubes. And the MCAD patient I told you about, she actually had to have one. And they invited me to her high school graduation where she was in a crop top and had a little scar from where her tube had been removed when she got old enough to eat on her own. So what about availability, diet practice? So should you throw away the butter and the mayo and put your whole family on a low-fat diet? Let's talk about that. So the American Heart Association recommends a heart-healthy diet as 30% of your total calories from fat. So if you eat a 2,000 calorie diet, that's about 66 grams of fat. Well, think about this as a typical American diet. Bacon and eggs, toast in the morning, tuna with mayo, chips, a couple cookies, Three Musketeer bar, because they advertise that as being low in fat. And then you're in a hurry on the way home. The larder's empty. You just stop in at McDonald's. You get a quarter pounder, fries, and a chocolate shake. And then later on, when you're watching TV, you eat 3 cups of Smart Food popcorn, because it's smart food, right? I mean, it should be good for you. And that actually would be 129 grams of fat and 3,100 calories. You would be quite round if you ate like this every day. And it's certainly not heart healthy. And even if you got rid of the chocolate shake, and just did a soda, you're still really up there. So sometimes in the US, a heart-healthy diet looks like a fat restriction because there's just so much fat in the typical American diet. And this I find sometimes hard to explain to the parents of new babies with MCAD. That like, well, no, I don't want to restrict your child's fat. But yes, I want to restrict your child's fat because I want them to eat healthy. And I want the whole family to eat healthy. So to some extent, yes, you can put your whole family on a heart-healthy diet and then do some further restriction for your long-chain fatty acid patient. So, can you eat a heart-healthy diet? I will tell you a long ago story before newborn screening for MCAD, when a baby came to town visiting grandparents, where I was on faculty in the hospital, and had a hypoglycemic seizure and was diagnosed with MCAD, then went home to their home med center where they did not have a board-certified biochemical geneticist and were put on a low-fat diet. And the child did not like the food that she was offered, and between 15 and 18 months, she gained no weight. And so they told the mother she would have to quit her job, they were going to put in a feeding tube, and she would stay home all day and feed this child. And so they came back to see me, and I was like, I put her in the hospital and said, I want to watch her eat, and she ate everything in sight. So it's like, you don't want to go overboard, but you can still consume a heart-healthy diet if you're a sibling of a long-chain fat or a parent of a long-chain fat patient or an MCAD patient, and you can still get some pretty good stuff to eat. You can have a little butter on your toast. If you use a light mayo, and you can have, a couple of cookies, a smaller Three Musketeer bar, a salad with a little dressing. This I put in for McDonald's. I use their nutrition for this regular size hamburger, a small hamburger with a small fries, and then, some cake and strawberries and air pop popcorn, even with a little butter on it. You could then get this to 68 grams of fat, which I had said at 2,000 calorie heart healthy, you'd be looking at 66. So you can still eat well without having to have a house full of, snack wall cookies. So for your long chain fat patient, you're going to need fat-free options. You're going to need fat-free cheeses. You're going to need, and hopefully if you can bake fat-free things, they're even better than what you buy. But I will tell you, 20 years ago, there was this big fat-free craze in the American diet, and all this fat-free food came out on the market. And what happened? People gained weight because, number one, they made up for the fat by stuffing sugar in it. And they were not any lower in calories, but people thought they could eat as much as they want. And number two, because fat gives you satiety. It tells you when to stop eating. Your hormones recognize that. So for the rest of the family, I would say yes, be heart healthy, use light mayo, be careful with your salad dressings, whatever, but I hesitate to say everything should be fat-free for the for the siblings and the parents, but I think you should be modeling healthy behavior. So nobody ever died from growing up in a house without double quarter pounders. Isn't that amazing? And Grandma was right. Moderation in all things. You don't want to go so crazy with fat-free with the rest of the family that you get people eating stuff that's full of sugar instead or not having satiety. But the kids are going to model how you eat. So you want to eat healthy. So if, you help the family make healthy choices by having it available. And deprivation backfires. If you leave kids hungry, they will just sneak food. And the same with force feeding. If you force feed them, you saw the video, chase them around the house for one more bite, you will set up behaviors that will interfere with healthy eating. So there's a lot of research right now showing that family dinners are important. And I grew up in a home with family dinners. And I remember talking to the nutritionist in my clinic saying, well, how do you eat if you don't sit down as a family and eat? And then I started kind of paying attention, and people just walk in the kitchen and get a bowl of something that's on the stove. And family dinners seem to be kind of passé, but they're important. Now again, moderation. When I was in high school, one of the most gifted athletes in my school had to drop out of the softball team because she had to be home at 5 p.m. for dinner. That was it. And practice was running late too often. And I mean, that's absurd. But on the other hand, you know, you can figure it out. So when somebody's got a soccer game and somebody's got, you know, football practice and somebody's got music lessons, it can be hard to keep family dinners going. But as much as you can within reason and without stepping on kids' dreams, try to have family dinners. So model healthy choices, try to have regular meals, try not to use food as reward or punishment. But the really most important thing is to never let them see you sweat. You just don't want to set up a behavioral relationship around food. So that takes us back here. Take care of yourself. Put on your oxygen mask first. And now I added these last 2 slides, not because I'm doing an ad for VMP, but because Stephanie actually asked me to. Virtual medical practice is a telemedicine practice set up by Dr. Mark Corson, and the main function of it is to provide support for physicians in hospitals that don't have a biochemical geneticist or that only have like one and they don't want to be on call 24/7, 365. And I work for them, so you take that as a but I really don't mean this to be an ad. But one of the things that he set up is this resource of the patient as teacher. So he's tried to establish a patient-teacher registry where parents, adult patients or parents, can register, and then if somebody locally is setting up some kind of educational program, they can call on you and ask you to come in and talk about your life experiences. And unfortunately, right now, he's a little too busy to maintain it. So when I called him last night to ask him about this, he kind of said, "Oh God, please, I'm overwhelmed right now." He is looking for a volunteer who wants to sort of manage this part of the practice, organize it, be a contact person for if somebody calls in and says, "I want a parent to come talk about a fatty acid oxidation defect or PKU or some other metabolic disease," hooking them up with the parents who have registered. So parents and patients would register on this site, and then you just need somebody to coordinate finding somebody who's the person who's looking and then finding. And so I did want to put up the website in case anybody wants to go there. But you can get it, if you go to the VMP genetics, you can find it necessarily without having to remember all the last bits of that. So if anybody's interested, Mark said once he finds somebody to take it on, he'd really like to enroll more families and more patients. So that was what I had to say today.
So we're going to move forward because we're running a little bit behind, but Dr. Arnold will be back for our expert panel. If you have any questions, save those questions, and we hope that you'll be able to ask those then. Before we introduce our next speaker, I just wanted to kind of talk